Good morning, ladies and gentlemen. We are here at the ESC TV studio in Paris, and we are talking this morning about a new scientific statement that we just published to tell and show how young EP physicians can help on their journey to become fully proficient in EP procedures. And I'm here together with Roberto di Ponti from Varese in Italy and Alexandre Almorad from Belgium, Brussels. And we're trying to tell you what we felt was important and the reason behind all of this. So I'm going to start right away with Roberto and saying, Roberto, you see one, you do one, you teach one. That was always the mantra, right? So the first question was always, have you done this already? And the answer was, no, I haven't, so you go and watch me one more time. That was the historic way of how teaching was done, right? The one-to-one experience.
I think that over the last decades, the scenario in medicine in general, but especially in cardiovascular medicine and in electrophysiology, has changed very much. And if 40 years ago, we just learned how to do an EP study and then how to do ablation and so on. So our learning journey lasted decades to arrive at this point using all technologies and being able to perform every kind of procedure. In this scenario, the young fellows who have to become proficient very fast in the new scenario, I think they have a very steep ascent to get all proficiency that they need. So the old master apprentice model doesn't work anymore. See one, do one and teach one does not work. I think that this should be remodulated in another way, introducing simulation. And that is my point. We have been working for some time with simulation, and there are different scenarios that can be simulated in a very sophisticated way.
Yeah, so simulators, of course, outside medicine, outside cardiology, that has been super established, right? So I think back on playing flight simulator on my laptop, I think feels like more than 25 years ago. And we are still stuck in a world, there are not that many simulators. So maybe you can outline what is out there right now.
So funny, this flight simulator reference. So this is not like, it's not there for more than 20 years. It's like more than half a century, actually. Early in the 70s, the certification based on simulation for pilots were already there and mandatory to fly with passengers. So we are really behind in cardiovascular training. In surgery, for example, it's also implemented more than 20 years ago now. Part of the curriculum, they have to have some skills acquired on simulation before performing any procedure on patients. In cardiology, we are very lucky, and in EP particularly, we are lucky. We have plenty of simulators. Heart simulators, online simulators, digital simulators with signals, with arrhythmia recognitions, with haptic feedback. We have different ones, but we are still not using them the right way. Some of us have access to them, but plenty of us don't, which is a pity. And also this discrepancy between all the simulators also don't offer this standardized way to the trainees to acquire very structured training. So I think that we are lucky in a way because we have plenty of simulators available, but then we have a lot of work to do to make a kind of curriculum based on the experts' experience to put like a kind of standardized way to teach and to evaluate.
So in a way, we have two tasks really. One is the understanding of reading electrograms. I think this is still the art in EP, and I think this is very important. And of course, this can be simulated relatively easy, and you could probably do it as an online feature even. So the access is kind of available for everyone, more or less.
Exactly.
And on the other hand, we have simulators that teach us something, this kind of muscle memory. What do you do with your hands? What do you do in which sequence? And that is, of course, a bit more hard to do at home, right? So, we have the simulation village here at the Congress, right? It's one of the big reasons to come on site and not to only attend online. But so where do you see it? How do we make it accessible really for people to come? I know Roberto ran a hands-on transeptal course for many, many years, and including
also
simulators,
here.
right? And also here. Yeah. So what's the experience? How many people are, if you look at the large group of people you want to train, how many people can we funnel into this kind of hands-on simulation, which I think is still a bit of a bottleneck, isn't it?
Ultimately, everyone. But as you said, there are two folds. The theory, which is most probably can be taught online on digital simulators at least. And this could be easily standardized because EGMs are well known, the different type of arrhythmias are well known, and so on. So this could be very easily standardized, I guess. It's hard work, but it could be. Then the practical part, and which should be like the second part of the curriculum. So it's a whole curriculum. This is, as you said, simulator-based. I think that we have an issue of geographical inequity, making it available for everyone. There are a lot of initiatives from industry mainly, because there's this gap that has to be filled. And I think the industry did a great job, but again, there is no curriculum. There is no scientific consensus on it. So there are initiatives also from the EP world, the clinicians like Roberto. I'm also involved, you are involved in a lot of training programs. But again, this is not standardized. Some initiatives are coming, like for example, EHRA, which is a European research simulator, where the idea is to provide a curriculum on different types of arrhythmia treatment, ablation, CIED, hybrid, with a clear support from EHRA. So it's a clear curriculum with a standardized endpoints and metrics to measure and to evaluate at the end the expertise of the trainees. So we have the simulation village, but the simulation village, so it's great because you could see and you can access all the simulators, but then again, you don't have metrics, you don't have evaluation, you don't have standardized outcomes at the end to evaluate. So I think that initiatives like society, clinician-led programs should be the standard. With what we propose in the scientific statement paper, we propose like training hubs a bit everywhere with simulators available for everyone. So the simulators go to the trainees instead of they're coming to the few centers to get access to the training programs. This is some of the proposals that we have. Of course, the road is very long.
Yeah, I think this is a little bit the way. And some of the statements in the scientific document is what we wish to happen in the future, right? Because we really don't have anything at the moment to evaluate.
And coming back to your question before, I agree. The simulator should go for everyone, from the novice people, the beginners, the more experienced, even for the expert. When a simulation can be fully developed, then you can, for example, scan a particular anatomy, then import in the simulation, then try the day before a complex procedure in which you have to do something particular. Then, on the other hand, the scientific community is the general opinion is quite split. There are people who are enthusiastic, and ourselves, but there are skeptical people. In fact, if you look in general at scientific publication on simulation in electrophysiology, there is evidence that in a way simulation training is better than conventional training. But on the other hand, the transfer of the proficiency acquired on simulation to patient-based procedure is scarce. And for this reason, again, we have not only to provide simulation curricula, based on the methodology that Alex has explained, but also to provide evidence that this proficiency transfer to the patient-based procedure, which is something that in the simulation world has not been done systematically, not even in other disciplines.
Maybe in surgery when in arthroscopy.
So part of this is how realistic is a simulator, right? If it's a very artificial environment, then it's so far away from reality that, you know, of course you learn something, but the transition from simulation to real exposure, I think is a big step in some simulations. And in some other simulations, you just mentioned that this is not only for the novices that we want to train up who just enter the field, but we also have techniques that are important for old and established and senior operators. You know, I'm just thinking of ultrasound guided puncture. You know, that made a big step. And I remember when we tried to introduce this, people said, no, definitely not necessary. I feel what I'm doing. I've done this for decades and I know this is good. But there is clear evidence that it's much better if you see where you're going with your needle tip. And to convince and make the kind of educational level so low threshold that they could all have a go on a simulator, yeah, and see the difference. And you know, we're lucky enough that these kind of simulations are relatively easy to even build at home. You can do it, and just even at your kitchen table if you wanted to, more or less with an ultrasound probe, to go and have a go without being exposed. And that's the nice thing about simulations, I think. You know, you can repeat it as much as you like.
Yeah.
Yeah, you can train yourself up until you feel confident, and that's the nice thing. You know, an exposure of patients in this, you know, is always just the one-off, right? So I think simulation has a great things to offer, but of course we need to demand and also continue to develop better simulations that get us closer to the real world scenario.
Agreed.
What do you think about training and training hubs? Again, removing the person who is going to be trained from the kind of cath lab environment. How different should that be? You know, if you're thinking back to the flight simulator, you're sitting in a kind of a whole kind of setup, and it feels like you're sitting in a cockpit.
Yeah.
Do we need to build cath labs to train in a cath lab scenario with the noises, with the distractions, with everything else? Because that's part of the challenge, really, to do your job well. Right?
Absolutely. We're in this world where EP, especially EPs, they have to combine intellectual with practical skills. So we have to be ready, you know, or the trainees have to be ready when they enter the cath lab to be able to think and to act. Mm-hmm. So this is something that if we want them to be trained as good as they should be, we have to be able to provide the same environment, or at least as close as we can get to. The full cath lab, I'm not sure, but at least a kind of dummy with some drapes on it, just to have like the feel that it's an operation room or a cath lab. Maybe a C-arm, depending of if they are doing fluoro or not, just to have this environment. And to be honest, if you have this and the screens, because you're implanting or ablating, then the environment is pretty close to the cath lab. Mm-hmm. This is my opinion. This is also because this is the way I'm doing it. I'm training people this way, so maybe this is how I feel more comfortable to do. But there are plenty of different scenarios.
The challenge in this scenario is the time allotted for this, because learning is an individual process which may take different time for different people. Mm-hmm. So in these cases, we have to be very strict in assessing the proficiency-based progression of the trainees based on metrics and on predefined benchmarks.
Yeah, benchmark.
Benchmark. I think this is a great closing statement in a way. You know, we need to not only dream about it, but also evaluate it and show the purpose that we achieve what we are set out to do. So I think we're going to close this lovely conversation this morning. Thank you very much for your attention, and please check out the scientific statement that is published today at EuroPace. And have a nice day and enjoy the rest of the Congress.